Hello, everybody. Happy New Year. This is Dr. Aida Wen, a geriatrician with the Department of Medicine, Geriatric Medicine at JAPSA. I serve as the course director and facilitator for this series. And our purpose is to empower the healthcare providers in the community to deliver age-friendly healthcare. Next slide. So a little bit about ECHO. We get free CME. There's distance technology, online learning. We have the opportunity for case discussion. We reach out to all our interdisciplinary team members, and we form this community of learning. So the ECHO motto goes, all teach, all learn. So we are relying on all of you to create this community of learning. Next slide. A little bit about our format. After a short lecture from our experts, we will share expertise from the rest of the team and then open it for a time of case discussions. We invite you to share any geriatric cases, even if it may not be the topic related to today's lecture. And all of our team is willing to teach and share our collective wisdom with you. We only ask you that you keep it HIPAA compliant for case discussion. Next slide. So yeah, we commit to maintaining and safeguarding confidentiality of information, and everything must be de-identified and HIPAA compliant in order to create a safe learning environment. We will also foster a culture of mutual learning and encouragement. So no negativity, no shame, no blame. It's all about encouragement. And as we were just chatting a little bit before, this talk began that we're going to begin this new year by encouraging one another, right? So also a little disclosure about ECHO. These consultations do not create or otherwise establish provider-patient relationships between any ECHO specialists and patients. This is purely just educational. Next slide. And here's our little calendar. If you haven't joined us before, we run the series on the second Wednesday of each month from 12 to 1 as a 1-hour session. We provide continuing education credits for MDs, nurses, and social work. This is our calendar for the next few months, so you can plan ahead and join us. And anyway, if there's any topics you'd like us to cover in the future, please let us know in the chat box and also when you complete your evaluation form. Next slide. A little bit on Zoom logistics. Move your mouse to the bottom of the screen to access the mute and the chat buttons. So just so you know, that's where they are. Next slide. And click on the chat tool at the bottom of the screen. Enter your name, discipline, and organization so we can have a record of who attended. And then after typing the information, don't forget to hit enter. That's our way of collecting attendance. Next slide. And of course, the mute button on the bottom left. So click on that when you're not speaking so we don't have extraneous noise. And then of course, we want you to unmute whenever to speak and to be involved. Next slide. Okay, and in order to get CME credits, you need to complete an evaluation form. And then the evaluations can be found on our website under the evaluations tab, and it will also be posted at the end of our session today, which we will be put in the chat box. Okay, next slide. Okay, and so without further ado, I am going to introduce our hub team. I guess there's me up here, Dr. Wen. As I mentioned before, I'm the course director for this ECHO Geriatric Clinic series. And we have Mary Gotham. Mary, can you show your camera and wave hi? There you are. She was at the Hawaii Department of Health. She's currently retired, but she has decades of experience in public health nursing. And we have Sarah Tompkison, and hopefully she'll say hi there. She has over 40 years of experience in geriatrics, health, mental health, and long-term care. She has served many years at the VA, served at Halikuike in memory care, and is currently a part-time social worker at Central Union Adult Day Care. And Chad usually is with us, but he is unable to be with us today. He is on military duty, serving us well. Okay, so let's see. So finally, let me see here. Okay, so I'd like to introduce our guest speaker. Okay, so the topic for today is falls prevention during COVID. And today's talk will be presented by myself. as well as Amrik Sidhu. And if he could wave, say hello to everybody. He is a physical therapist at Genesis Rehab, and I worked with him closely when I was over at the Villas a few years ago. Anyway, so both speakers have disclosed that we do not have any relationships with commercial supporters that could be perceived as a conflict of interest in the context of this presentation. And I think that's it. And now on to our presentation, on with the show. Okay, great. And it's good to see everybody here in the chat, I like to see all the people attending, and I see lots of familiar names and lots of familiar faces, and really appreciate everybody joining here. Okay, so falls prevention during COVID. Next slide. Okay, so we're just going to start off with, with a patient scenario, right? So you get a call from Mrs. Z's wife that he had just had a fall out in the garden today. Fortunately, he had no injuries, but he was a bit shaken. This was his second fall since March of 2020. He used to go out several times a week to visit friends, but he has stopped going out since the COVID pandemic started and pretty much stays inside, except to do a little gardening with his wife in their small yard. He doesn't want to go to the hospital or the doctor's office as it is too much trouble due to COVID risk. He actually has to take 12 steps to get down, so it's too much trouble for him. He is 85 years old and he has a history of hypertension. He has some mild kidney disease and a history of colon cancer that was treated surgically about 7 years ago. So the question is, how can we do a falls assessment, evaluation, and treatment to prevent falls in the future? And how much of it can actually be done remotely? Next slide. So just to start off with a little background, falls is very common. About 25% of older adults fall each year. About 1 in 5 results in serious injury, that is fractures or head trauma. About every 20 minutes, an older adult dies from a fall. That's pretty common, and it's actually the leading cause of death from injury in persons over the age of 65. And causes are multifactorial. Next slide. Falls are very expensive. Falls cost the U.S. over $31 billion a year. Falls are associated with increased medical services. Ambulance rides themselves are quite expensive, not to mention the emergency room and then the scans and the tests and everything that goes along in there. There's also decline in functional status that often occurs with that, as well as nursing home placement. And then there's this syndrome called fear of falling, which it actually impacts well-being and psychosocial functioning, and falls are preventable, potentially preventable. So we should do what we can to prevent. Next slide. A lot of what I will be sharing with you today comes from the AGS, American Geriatric Society, Geriatrics Evaluation and Management Toolkit. This is the GEMS toolkit from AGS. And so that's where a lot of this comes from. Next slide. Okay, so the first thing we need to do from a medical standpoint is we need to get a good falls history. We need to be asking Mr. Z, what kind of symptoms did you have? Did you feel lightheaded? Were you dizzy? What was the frequently does this happen? Did you have any injuries? And, what's the nature of those injuries? Was he having trouble with mobility before? Was he using assistive devices? How much of the activities of daily living has he been able to do on his own? So it's really important to get a good falls history, get a sense of where this problems might lie, because usually it's not just one. It's, like we said before, multifactorial. Next slide. And, if we just looked on the outside, we may or may not see that much. It's really what's on the inside that matters. So a lot of these medical conditions, we need to dig a little bit deeper in and look into the chart and actually ask him all about these kinds of things. Is there any problems with vision loss, motor weakness, cognitive impairment, urinary incontinence that cause them to run to the bathroom, history of stroke, cardiac issues, um, uh, like irregular heartbeats, pacemaker, things like that, neurological disorders, diabetes, predisposing to hypoglycemia or hyperglycemia, seizure disorders. These things, a lot of these things are invisible, but these are what are causing many falls. Next slide. And the other thing that physicians and pharmacists will be assisting with is reviewing those medications thoroughly, because and including those over-the-counter medications. There's things like the Beers criteria and the stop and start criteria, which actually list high-risk medications for older adults where the adverse events may outweigh the benefits. Looking for drug-drug interactions, particularly focusing on antipsychotic meds, benzodiazepines, opioids, uh, things that may cause orthostatic hypotension, things like blood pressure medicines and diuretics, like those water pills, hypoglycemia medications, and the proton pump inhibitors, which actually may increase the risk of osteoporosis and fractures. Next slide. Of course, we must not forget their social history when we do an evaluation, including asking about alcohol. Alcohol and substance abuse in older adults is very hidden. It's under-recognized and underreported, and if we don't ask, we won't find out. So it's important to ask. Important to also find out what kind of social support they have, and are there any supervision needs. So those are very important in terms of trying to gather a plan going forward for the assessment, evaluation, and treatment. Next slide. Next slide. Okay, so when performing a physical exam, it's important to get orthostatic blood pressure, especially when they're talking about dizziness or lightheadedness on their as a part of their story. However, I must say that there are some people who are orthostatic and they do drop their blood pressure quite a bit and have no symptoms whatsoever. So yeah, it's important to get those vital signs if possible. Doing a cognitive evaluation. Sometimes people with very mild dementia will have issues with poor safety awareness and things like that, poor judgment. Of course, cardiac, getting assessment of their gait and their balance using a tug test and the Berg, which Emric will speak to us about later. Strength evaluation, and then physician will do a good neurological evaluation, including reflexes, looking for focal deficits, any signs of neuropathy, tremor, rigidity, things like that, and then taking a good look at their feet and their footwear as well. Next slide. And depending on the history and what we might be concerned about, we may be ordering labs and imaging, particularly looking for evidence of dehydration or hypoglycemia, things like that, anemia for weakness, infection if there's some concern for delirium. Oftentimes falls is almost the first sign of delirium or infection due to an infection or something else. Um, we may be also checking vitamin D levels as well as a vitamin B12 level. As vitamin B12 and folate can cause problems with neuropathy as well. Bone mineral density, looking for mostly, and vitamin D levels, mostly looking for risk for fractures. And then based on the exam, considering whether to do an electrocardiogram, neuroimaging, that's a CAT scan or MRI, or spine imaging, depending on what's found on the exam and the history. Next slide. Additional recommendations is, assessment of proper footwear, referral to physical therapy, and ask them to perhaps consider an assistive device review. Maybe the assistive device isn't working quite so well as it was before. Maybe it's time to use something else. Home safety evaluation is also very helpful and insightful. We may need to provide environmental modifications such as lighting and bath mats, and may need to lower the bed. Other medical equipment might be warranted, such as a toilet riser, bedside commode, urinal, shower chair, things like that, or even the need for more assistance and supervision. Next slide, please. And Amri, you can go ahead with the screening and evaluation. Thanks.
Thank you, Dr. Nguyen, and good afternoon to everybody. Again, my name is Amrik. I'm a physical therapist. I have a doctorate of physical therapy from University of California, San Francisco, and currently employed with Genesis Rehab Services, which provides therapy services, PT, OT, and speech for a number of skilled nursing facilities in Hawaii. Next, please. So we want to talk a little bit about screening versus evaluation because a lot of times they can sort of be interchangeable, but there is a slight difference. We consider screening as more of a hands-off approach. So it might include something like a questionnaire, and I'll give you a couple of examples of common questionnaires as they relate to fall risk. We definitely want to take into account history, and I think Dr. Nguyen covered that pretty thoroughly in terms of medical history, but we also want to ask about a fall history as well. Of course, we want to gather information from the family, nursing, and other caregivers that might be involved, depending on your patient's ability to provide accurate historical information. But the purpose of a screen is really to answer the question, is a further evaluation indicated? And evaluation should include the use of some tests and measures, which we'll go over a few examples. We want to have a thorough examination and assessment at that point, so more in depth than a screening process, and then really translate into developing a treatment plan or a plan of care, which should have some goals and outcomes that can be measured. Next, please. So a few screening tools. One thing that we want to consider is the risk factors. So the biggest risk factors as it relates to falls is a fall history. So even one fall is predictive of fall risk in the future. So we definitely want to be asking that question if we're assessing an older adult for their risk for falls. We want to take into account cognitive and physical impairments. Certainly cognitive, sometimes that can be obvious, but sometimes it's not as obvious in terms of, ability to learn new information. Is that person gonna, reach out for help? Are they gonna do things that they think that they can do because they've done it their whole lives, but now they're no longer safe to do those? Could be something as simple as getting up and going to the bathroom, or something more complex like making a meal or doing laundry. So we do want to take a look at the cognitive impairments of the individual, the safety awareness, as well as the ability to learn new information, like using a walker for the first time, for example. Physical impairments, sometimes again that can be obvious, and other times maybe not so much. And there are a number of aspects that we need to look at, from balance to flexibility to strength, and we'll kind of take a look at some of that as we go. Unsteadiness and fear of falling might seem obvious, but we definitely want to take that into consideration as a risk factor. And for more medications, of course, if we don't always know how that number of medications can interact, and it can cause changes in blood pressure and other things that Dr. Nguyen described earlier. And other screening tools that I mentioned could be fall risk questionnaires, specifically the Falls Efficacy Scale and the ABC, otherwise known as Activity Specific Balanced Confidence. So let's take a quick look at those in the next slide, please. So here's a screenshot of the Falls Efficacy Scale. So it's a 1 to 10 scale. You might say similar to a pain scale, except that it's flipped. So 1 is very confident and 10 is not confident at all. And so you would just simply ask these questions on a scale of 1 to 10, how confident are you? And a score that totals, I believe it's less than 70 is a high risk for falls based on a questionnaire. So the clear advantage is that it's easier to administer, and you're not having to do a physical examination. So of course, in our world of COVID, I do think that we're finding that older adults are at a higher risk of falls. Maybe, they aren't getting as many visits, they're not as active, they're not out in the community, So it leads to a little bit more sedentary, more isolated sort of lifestyle over the past year. And we are seeing an increase in risk for falls. And so this is something that can be easily administered even over the phone or by telehealth, which makes it a useful tool because you may not always be able to perform a physical examination. The next slide, please. We'll take a look at the ABC scale, which is somewhat similar. Again, the activity-specific balance scale where the individual would rate their self-confidence. So both are relating to self-confidence in performing functional tasks. So they're both useful tools. And I know these are just screenshots, so we do have some links to these resources, or a simple Google search should also take care of it as well. So just wanted to share these with you. Go to the next slide, please. So some further evaluation tools. So we definitely want to take into account the questionnaires, but it also may involve some physical assessments at this point. And so a sit to stand in 30 seconds test is a great strength assessment. There's a lot of different ways to measure strength. We like this particular tool because it is directly related to function, the ability to sit to stand within 30 seconds, and we'll talk more about that. So it's a functionally based strength assessment tool. The tug or the timed up and go, we'll talk a bit about that, but these are all evidence-based measures, and this one directly correlates to ADL, and that's somebody's ability to perform activities of daily living, things like getting to the bathroom, getting dressed, taking a shower, as well as higher level activities like cooking or doing laundry. So this is a great assessment to measure somebody's ability to perform those activities without having to actually go through each of those activities of daily living. The Berg balance is really our gold standard assessment for balance, and we'll take a look at that, as well as a couple of other balance assessments, including the single leg stance and functional reach. So let's take a look at those on the next slide, please. So again, in order to evaluate a sit to stand and test in 30 seconds, again, this is a measure of lower body strength, but really more importantly, functional strength. So some required items, you're going to want to have a facilitator. So if you're not able to perform this test in person with your patient or your client, then you definitely need a facilitator, which could be a family member or a nurse, somebody there to ensure the safety, assuming that the individual that you're working with is at a risk for falls. You would need a stable chair. It may or may not have armrest, depending on the functional abilities of the person whom you're assessing, and a good old-fashioned stopwatch, which of course can be found on your iPhone. So you would have the subject in a seated position, sitting at the edge of the chair. The test is supposed to be performed with the arms crossed. So sitting at the edge of the chair with the arms crossed, that means that they're not using their upper body in order to perform this activity. So, if somebody's not able to perform a sit to stand without the use of their arms, then you can perform it with the arms either on the chair or on armrest, but that should be noted that the test was performed in a modified fashion, and that does indicate lower body weakness. So again, it's just simply standing up and sitting down as many times as possible in 30 seconds. So use of hands indicates lower body weakness, and less than 10 repetitions in 30 seconds also indicates lower body weakness. So a great tool that obviously can be done in about 30 seconds to assess somebody's functional strength. Next slide, please. So here's our tug, our timed up and go. Again, directly correlates with activities of daily living. So again, we need a facilitator, somebody to be with the subject to ensure their safety when performing. Again, a stable chair, a stopwatch. We need to measure out 3 meters, which is 9.8 feet. And they may or may not need to use an assistive device such as a walker or a cane. So if they normally ambulate within their surroundings with an assistive device such as a walker or a cane, then you probably want to perform this test with that device. That way you understand what their usual performance is. But again, it should be noted as a modification to the test. So from the seated position, this time seated all the way back in the chair. The subject would stand, walk the 3 meters, turn, that'd be a 180-degree turn, so that 9.8 feet should be measured out and marked with a tape or a cone perhaps. Turn and then sit. So the stopwatch starts from a seated position and then ends in a seated position. So here again, less than 10 seconds indicates an impairment. So this test also correlates with strength and it also correlates with balance, but it's really just a great tool to measure somebody's activities of daily living. So the next slide, we'll take a look at a balance assessment. So the Berg is what we consider our gold standard. It does take a bit more time to administer. You would need 2 chairs, a yardstick, a footstool or a step, and a stopwatch. There are 14 different tasks, so we're not going to cover each individual task, but it includes things like transferring, single leg stance, turns. It also takes into account somebody's flexibility, strength. So you would score 0 to 4 on each item. So the highest score would be a 56 on a Berg balance test, and a score of less than 45 would indicate a high risk for falls. So this assessment's a bit more involved, and we realize this might not be the most efficient tool to use. So we wanted to give you a couple of alternatives that don't require quite as much time. Next, please. So the functional reach, again, the evidence shows us in the literature that if you're going to take one single test to determine somebody's risk for falls, it would be the functional reach. It should be noted that the functional reach as well as the single leg stance are both included in the Berg balance. So the Berg balance is going to be more comprehensive, but if you just had to take one single test to perform to determine somebody's risk for falls, again, that's going to be the functional reach. So you do need a yardstick, as you can see demonstrated in the picture there. It'd be affixed to a wall or some surface. I've seen in gyms, we fix it to, various surfaces. Doesn't necessarily have to be a wall, but then the subject would be standing without touching the wall, without leaning onto anything. The arm would be forward stretched, as you can see there, and that would be your baseline. That's your starting point. Then you would instruct the individual to lean forward as far as possible and measure the distance that they're able to reach forward. So this picture is pretty well demonstrated. The starting position is upright with a fist, or it could be an outstretched arm, but technically it should be a fist, and that they're leaning forward. So what we're really measuring here is somebody's ability to shift their weight forward, which again is highly indicative of risk for falls. So a score of 6 inches or less is a high risk for falls, and if they're between 6 to 10 inches, that's a moderate risk for falls. So really, an individual should be able to reach further than 10 inches. Then there's also a single leg stance, which is really great because it's just so easy to perform. You really don't need any special equipment to perform that. It's just the ability to stand on one leg. The goal here is 10 seconds or greater. So if somebody's not able to maintain single leg stance for greater than 10 seconds, that's indicates a risk for falls. Now, in the older adult population, depending on the individual factors of that person, they may not be able to perform this test at all. Now, it's important to note, I've met a lot of folks who say, I don't, stand on one leg very often. Why do I need to be able to stand on one leg? But if you think about the gait pattern, the reciprocal left and right, we're essentially standing on one leg every time we take a step. And so it is important to be able to perform this test. And, there are some other modifications like decreased base of support. So putting the feet together or standing in a tandem formation, like almost like walking on a tightrope. So there are some other variations depending on the abilities of the person that you're assessing. But we just wanted to give you a few quick tools to use to assess an individual's balance. Next, please. So let's talk a bit about treatment. And treatment obviously is a very, very broad subject that we could spend a great deal of time on. But just some few key items. So if we're looking at strength, again, we want to have a thorough assessment to determine where the impairment is, because there's so many muscles in the body that can be strengthened. lower body, upper body, left versus right, agonist versus antagonist. So you really want to be sure that you have a clear understanding of what that impairment is so that you can target that particular muscle group for strengthening. And really what the evidence shows us is that we need 60 to 80% of a 1 rep max. And so what that means is, for example, let's say we're strengthening somebody's bicep muscle. And so you do an arm curl. You really want to determine what somebody's 1 rep max is. So that might be 20 pounds or it might be 50 pounds. The ability to perform whatever that weight is to perform one time. And then you would take 60 to 80% of that, and you want to have that person repeat it roughly about 12 repetitions. That's the only real way to build strength. So, I see in a lot of gyms, the use of TheraBand and maybe 5-pound weights or 10-pound weights. And while that might be useful in some ways, it's not going to truly rebuild strength. So I just wanted to kind of put that out there. If you feel like strengthening is going to be part of your treatment approach for your patient. Balance is a very complicated subject to discuss. The components there's really 3 components of balance: visual, somatosensory. Somatosensory is the information that we get from our joints. If you can imagine walking on a rocky surface or on a beach, your joints and your receptors are sending a lot of information to our brain. So our brains combine that with our visual and our vestibular. Of course, our vestibular is our inner ear. And so that's why sometimes people feel ill on a roller coaster, because they're getting all this very intense information that's really not jiving with one another, and kind of makes people gives us motion sickness when all these different systems are working against each other. But all these systems, when they work in harmony, give us the ability to stand upright and walk without falling. Right. And so, again, that's something that can be assessed in a clinical setting, but we just need to be aware that balance is very complex and not something that we're able to comprehensively cover in a presentation like this. And now, fall prevention, we have different strategies that we all employ in our daily lives without ever even thinking about it. And it really starts at the ankle. Our ankle is our first sort of line of defense in preventing falls, and then it goes to our hip strategies. Imagine, kind of leaning forward to prevent a fall. And then if you're really off balance, then you would take a step. And so these are all things that can be trained in a clinical sort of setting, but it is rather sort of complex. I would say that if you're really trying to simplify strength and balance training, focus on function. What is it that you're trying to accomplish, and really focus on that functional task. Endurance, again, determine what task needs to be completed. It could be as simple as getting to the bathroom, or it could be something more complex like laundry and cooking, like we've discussed. Gait and ambulation, I think it's wonderful as a physical therapist. Of course, this is something that we focus quite a bit on. It should be noted that gait and ambulation in itself is not an effective treatment for balance. So it should be used in conjunction with other specific treatment approaches. And then there's compensatory strategies. Maybe the use of assistive devices might be indicated, like a walker, cane, wheelchair. There's all kinds of various, bathroom DME or durable medical equipment. And so it should be part of a comprehensive treatment plan. So next, please. So that might be something that might be best to be referred out. So there's lots of different areas of expertise out there. Of course, physical therapy tends to focus a bit on balance, ambulation, strengthening. Occupational therapy, or OT, tends to focus a bit on ADLs and quite a bit on the compensatory strategies. Speech language pathologists, do you play a role in fall prevention? We definitely want to consider those cognitive impairments, and there could be some expressive and receptive issues there that may be sort of confused with cognitive impairments, and that wants to be teased out. And so speech therapy might be indicated for a particular individual. Home health referral, right? So home health is wonderful, especially in the age of this pandemic, because a lot of folks don't want to leave their homes and may not be able to use public transportation the way that they used to. It should be noted that somebody needs to meet a homebound requirement in order to qualify for home health. but home health can provide PT, speech, as well as nursing care, depending on what your individual might require. Or there might be an outpatient referral might be more appropriate, which again, one of the big positives of an outpatient referral is that there's a lot of gym-based equipment, things to really do a really great assessment, as well as thorough treatments, because it really is quite a complex subject. And so this is just meant to be an overview to sort of get the wheels turning. Next, please.
Yeah.
Go ahead, Dr. Nguyen.
Yeah. So I just wanted to just also kind of use this slide to underline the fact that we need to engage the patient, and it's not just about, we make a plan and then we carry it out, because the patient isn't engaged and they don't really want to do it. We all know nothing much is going to happen. And so I just pulled up this it's a CDC website, and you can find this and you can print it out and you can share it with your patients and sort of help them sort of get engaged and make a plan for themselves to try to stay independent and mobile. And I'm going to maybe have some of our social work colleagues talk a little bit about this as well from their standpoint. Okay, next slide. Okay, so now I'm just going to come back and we're just going to do this patient scenario revisited, and then going to invite some of our hub team here to just comment on some of these issues here. So, so you get a call from Mr. Z's wife. He had just fallen out in the garden today. He had no injuries, but he was a bit shaken. This is his second fall since March of 2020. He used to go out several times a week to visit his friends, but he has stopped going out since the COVID pandemic started. Pretty much stays inside, except to do a little gardening with his wife in their small yard. He doesn't want to go to the hospital or the doctor's office as it's too much trouble. 12 steps down, and he thinks there's a high COVID risk. So he's 85 years old. He has a history of hypertension, mild kidney disease, and a history of colon cancer. So my thoughts initially is, let's see, what's his circumstances that he's falling, and if it's outdoors in his garden, could there be uneven ground? Could there be dehydration? Is it too sunny out there? Things like that, and kind of trying to target evaluation of some of those, looking at orthostatic blood pressure and looking at his blood pressure meds, and a little bit of a neurological eval, and some of the balance, focusing some of the balance testing. So those were some of my initial thoughts in terms of evaluation and a review of his medications. So I would like to open this up a little bit to some of our colleagues here on the call. So Sarah, from your point of view, you are a social work. What do you think about?
Well, because he's had previous falls, it's noted in March. I think this person, though he says it's too much trouble to walk 12 steps down his home, I have seen, unfortunately, many people, once they've had a fall, they're really afraid that another fall is going to happen. And fortunately, he didn't need to be hospitalized, but specifically with falls, any kind of fall, this person may also just at this time be really anxious. He's at risk for being anxious and afraid to leave the home. And that can really change the dynamics of relationships and lifestyle that you would have normally had. I was going to ask Dr. Amrik if you see that as well when you're working with clients that you're trying to rehab and they've fallen quite a bit.
Absolutely, and I'm glad that you brought that up. That the history of falls, again, even just one fall is a good indication, and he's already had two, right? Luckily, no injury, but the next time might be different. So the other, big question I would ask about this, Mr. Z, is what's his support system? we have a call from his wife, but what is her health? What is she able to provide? Do they have other resources? Is there other family? Is there friends? Is there, church groups or other resources that can assist in this? Because he's clearly at a high risk, and we want to keep him at home, and he doesn't want to be in the hospital either, right? But
Right.
headed in that direction without proper intervention.
Well, and I think the other piece to think about is how we have the technology. And I think you're going to, as we further discuss the case, with the technology we have, it's not just only doing telehealth, but we have special alarm systems that can be set up where a person can wear a device on them, or they can have a device placed in the home. Dr. Nguyen, isn't there even some devices that can predict a fall before it even, like the person's, my iWatch, by the way, my iWatch, everybody does that. I didn't exactly fall because I want to be a falls risk, but I was in the yard, and it was raining, and all the the things I shouldn't do, I did. And so I slipped, but it told me, alarm came up, said, "Oh, are you okay? Did you fall?" And do I need to call? And I said, no, I can't fall. So can you speak to that, Dr. Wen, too?
I don't know too much about some of these fancy tools, but I know they do exist, and they're getting fancier and fancier every day. And I see Noreen is here, and she may know some stuff about remote monitoring. Do you want to say anything, Noreen?
Some of the devices are getting better with the artificial intelligence, and they can measure heart rate as you're falling. So they're coming up with better devices to wear, as well as a monitoring system in the homes.
My 2 cents on that is they can be very useful, but by the time a fall has occurred, it's too late. And so it's really all about prevention.
Mm-hmm.
Right.
Mm-hmm.
I agree.
Yeah. Okay, so I see there's a question in the chat box from Catherine Shawhan. She was wondering if, Amrik, if you have experience with pivot wheels on front wheel walkers, and it prevents lift and I think it's turning risk patterns or something like that. Can you speak to that?
Sure. There's so many different kinds of devices out there. I would say that for folks who are at risk for falling and that need some sort of assistive device for ambulation, the gold standard is what we call a front wheel walker. And there's really 2 reasons we like the front wheel walker. One is that it's very simple, right? There's no brakes, there's no swiveling wheels, there's no other, bells and whistles on it. And number 2, it's very stable. So it stands on its own, it's not easy to tip over. So simple and stable is the way to go for a lot of older adults. That being said, there are so many, variants to that that might be appropriate. It just really depends on each individual. And so that's where the thorough assessment really comes in. And, we want to, we want somebody to be as independent as possible, right? So giving somebody too many compensatory strategies is not a good idea either, because you're going to take away some of their own sort of strength and balance, opportunities, right? So we have to really strike that safety and independence sort of balance.
Yeah, Sarah put in the chat box that the State Department of Health EMS and Injury Prevention System branch is another resource for falls prevention guides, and they have certified Tai Chi classes.
Yay!
I think, Sarah, are you a Tai Chi teacher?
I am.
I thought so.
And that goes along with how you both spoke about the importance of engagement with the patient, because really, if you're going to get compliance from anybody, you really have to kind of hone in on what the person's really going to be interested in. And Tai Chi really has a functional purpose that you're speaking to, Amrik, because indirectly it does help with people's balance, because for the particular style we teach, it has to do with the transferring of weight from one leg to the other before you actually move. So
absolutely. And I think we're only beginning to learn more and more about how functional and how useful Tai Chi really is. I mean, there's some really wonderful things. I mean, it's some wonderful implications for folks with Parkinson's, and in terms of your body symmetry and movements, initiating the movement. they're slow, controlled, purposeful movements. There's so many wonderful benefits. I think we're only starting to really study and understand.
It's moving meditation.
Right.
Like yoga. Yeah. So Amrik, here locally in Hawaii, and I'm not just here, but I know that with families I work with, a lot of them have equipment that they've been passed on to them from the neighbor or from a friend. And my mother's, truth be told, there's one of them. So my mother didn't want to use the front wheel walker because she was offered from the neighbor another walker that had a basket that she could sit on. Can you speak to, are there any risks involved when you are using other people's canes or walkers or?
Sure. Well, as a physical therapist, I've seen that quite often, and it can be wonderful, and it can be very, very appropriate. And we always appreciate people's generosity. Everybody's in a different place, financially or in terms of resources. But we do want to make sure that it's the right or the appropriate device. So as long as it's the appropriate device and as long as it's in good working order, so it does still require some sort of assessment. Again, it's so individual that there's no one answer on that.
Great. Okay, so I just wanted to also mention in the chat box, Catherine again mentioned she talked about a garden scenario. She's worked on adapting garden setup for client safety. Catherine, you want to share?
Sure. I'm an occupational therapist. Can you folks hear me?
Yes.
Okay, I'm working on my iPad. So yeah, I've done home visits with repeated falls outsides at favorite activities that people aren't going to change their pattern too much of what they like to do. And I was really surprised. The families will really step up and make changes out there to accommodate some of these favorite activities. And it makes a big difference. I had an elder lady that insisted on going out to take care of her lo'i, and that's where she fell. So they raised it up. By the time I came back for another visit, she could sit beside it and work it, and no more falls there.
Wow.
So sometimes accommodating, like we were talking about, personal assessments of their patterns that put them at risk, and and if there's cognitive issues, finding a way to accommodate, to work around those.
Yeah.
It was really fun. It was really fun to work with.
Yeah. So actually, this raises an interesting, very important important issue, that of the home visit. Actually going in to be able to see, because the patients don't necessarily tell you what's going on in the office. You don't actually see what the home is like and the environment and things that they like to do. So, yeah, Mary, I know that you've done a lot of home visits. Do you want to share any insights from that you've seen?
Well, I would just say that, yeah, in this situation, if I got the call, I would want to go out and take a look. Public health nurses have been trained to assess and intervene with falls and see what all is going on, the environment and everything, and then possibly, calling a doctor if it's okay with the couple, to see if the doctor could order a home care PT, since it sounds like this man is homebound and stuff. And then just working with the wife. I mean, the wife is upset. It doesn't say, she called and said all these things, but what does she want? What is she's hoping to have happen? I would ask her, what does she think would help? And so I think the real value of the nurse or the social worker that goes out and takes a look and sees what's going on and develops a relationship with the family and works over time, being creative to find a unique answer for this couple.
Yeah. So we have to find some partners here, right, to do that. We have some folks from Care Resource here. You want to speak up on that? Arnold?
Hi, this is Arnold.
Yeah.
Hi. Yeah, I'm from Home Health from Care Resource Hawaii. Like Mary is saying, this patient will meet the homebound criteria for home health. So it looks like, due to the illness, it will be difficult and taxing for the patient to leave the home. And also with the CMS COVID-19 pandemic, they're saying that patients with high risk for the virus will meet the criteria for homebound. And this scenario is very familiar because we're getting a lot of referrals from our PCP about possible home health referral. And it looks like, yeah, this patient will, because of the history of falls, there's a lot of things that we can do in home health. Not just for PT, it looks like this patient will also need a nurse, will also need an OT, like what Catherine is saying, to assess their current ADLs in the home, and possibly a social worker. Yeah, we can provide, like what Amrit is saying, all those tools and tests that we can do in the home. We can create a unique or specific plan of care for this patient, and we can conference with the doctor to see what we can do to keep the patient safe at home during this pandemic.
Great. Yeah. So actually, I want to, actually, if you could forward the slide, please. Just the next couple of slides, I just wanted to just mention that the CDC has a bunch of resources, and I think in the chat box a little bit earlier, Jeff Galbraith mentioned one of those, but the CDC has a ton of stuff from SETI resources. They have videos and explanations. They have patient resources, clinical resources, provider training resources, pharmacy resources, and all kinds of stuff that I would encourage everybody to go take a look at. They're really, really helpful. Next slide. And there are other resources here as well that Emric posted about instructions and scoring of how to do each of these different scores. So I'd like if, John, if you could just take the slides down, do the unshare screen. That way we can actually see the participants, which I like to do. Okay. Okay, great. And so let's see. So I see a couple of things in the chat box. Let's see. Catherine, let's see. Oh yeah, so Michaela says, don't forget to do your evals on the link afterwards. Catherine again talked about, she worked in home care for many years, very limited in working with creative solutions, very wrapped up in homebound requirements and documentation, and found those skills services are very tight and provision are limited. Possibly, but I'm sure, I think some people are very, very creative. A lot of people in geriatric care are very, very creative. And Catherine, I have to say, when you talked about that garden idea, I said, oh, spoken like a true occupational therapist, right? But yes, our families are also very, very, very resourceful. Diane mentioned about the Lanakila Senior Center. Diane, do you want to speak to that?
Sure. I just wanted to share that, we, the agency identified falls as a major risk factor for our senior center, because when we report incident reports, that seemed to be a common thing. So we actually implemented doing the sit stand, and we actually we used to do the tug test too, but I think they've stopped doing that. But they do it with all the seniors who come in as new participants to the center, and when they do the annual referral reassessments, in order to determine if people are reaching a point where they maybe need to look at assistive devices and other things. So our membership person then makes the referral to our social worker. So we're trying to catch people because they age in place at our center. And, some of them are 20, 30-year participants. So over time, their fall risk increases. But very difficult sometimes to get people who are used to not using an assistive device to then use it. There's a lot of social issues, particularly when, you're in a group program like the senior center. So they have had to stop doing those tests because obviously the center is not open for group activities right now. But, we intend to start that again when we are able to reopen.
Yeah, so I'm going to jump down. There's another comment by Sarah Tompkinson. The Central Union Adult Daycare Center and Day Health does offer some outpatient contracted PT services when recommended by PCP. So if you are fortunate enough to be involved in adult day, or you want to get involved in adult day, some of them are actually open even now, even though, you know, smaller census and all that sort of stuff. And I guess you can get some in-person exercise and therapy at those scenarios. And Amanda Galdi posted a question about high-risk patients. Like, what do you recommend for prevention when there's no home visits? And we spoke a little bit about, you know, I think, you know, obviously, you know, doctors, there are some docs who still do some home visits, but of course they're very far and few between, and there's a long waiting list for geriatricians who actually do this. But, you know, home health agencies still go to homes, and they're still able to be those eyes and ears for us, and we can probably work very, very closely with them to try to get their input and recommendations for basically being able to do those assessments for us. And of course, there's the whole bunch of resources possible and things that, with regards to patient empowerment, that patients and families can do on their own as well.
Yeah.
Are there other things you might recommend, Amrik?
You know, I would just add that the single most effective intervention, and this didn't make it to the slide, but the single most effective intervention is going to be education. So whether that's safety education or an exercise program kind of education, and you have to consider more than just the individual, but also the family and the other resources, because we really need to educate Mr. Z's wife and children and caregivers and everybody around him, because he needs that support around him. So that's really the main intervention, I would say.
Yeah, I actually would echo that. I think people don't realize that something can be done. They just think, oh, just getting old. You know, that's how it is when you get old. But, you know, when you can actually educate them, say, no, actually, you can do something about that.
And I like, just to ditto what you said, you know, the point is falls are not a natural part of aging.
Right.
So that's the biggest takeaway for me.
Yeah. And that for this, I mean, it's a good thing the wife reached out, because if she hadn't and he just fell and she said, well, he didn't get hurt, no problem, thank you, that was great, phew, we're lucky, and nothing was done about it, that would have been a big lost opportunity. But now we actually have a huge opportunity to really jump all over this and look for the underlying cause, you know, with screening, as well as getting a PT/OT evaluation, a home visit, and also providing exercises and opportunity to provide, you know, home modifications or whatnot, you know, and assistive devices and things like that. So great. So, oh my goodness, it's 1 o'clock and time just keeps flying away from us. So anyway, thank you all for joining us. In order to get your CMEs, don't forget, get on that webpage and click on the link, indicate the type of CE you would like, and also please include any comments, future topics that you would like to see. And next month, our next session will be February 10th, and the topic will be advanced care planning during COVID, presented by Dr. Takeshi Uemura. And just want to say thank you very much. Round of applause for everybody who participated and contributed and spoke and shared. Thank you so much. See you next month.
See you next month.
See ya.
Oh, what did I do with it? Dying.